I'm Michael Ratney. Welcome to the American Academy of Diplomacy. This is my first time I've been in this new office. This is Ron Newman. He's the president of the Academy. Thanks for joining us. I'm a relatively new member of the American Academy. I was a retired Foreign Service officer. I joined the Academy last year. My experience is not public health or pandemics, but we have some real experts on that. Just quickly, for folks who aren't familiar with the American Academy of Diplomacy, the mission is to support and strengthen U.S. diplomacy and the U.S. public's appreciation of the critical role diplomacy plays in advancing our national interest. Just to be clear, it's not an organization that typically makes comments about specific aspects of foreign policy. It is generally here to strengthen the public's appreciation for diplomacy. And we were at the annual meeting yesterday, and it was, I was just remarking, the amount of experience in that room was staggering, literally centuries of experience in diplomacy and development. It's a nonpartisan organization, but not surprisingly, and this came out yesterday, our members have strong concerns about what we think is the effective dismantlement of American diplomacy. As you know, the current administration has essentially demolished USAID, dismissed and forced out large numbers of diplomats, including many of our most experienced officers at the State Department. Now, those decisions ostensibly made in the name of diplomacy, but what they've actually done suggests something else, something that seems more like an ideological contempt for expertise and foreign affairs experience. Their decisions also have had serious consequences, and one very current example of those consequences is what we're here to talk about today. So this morning, we'd like to talk to you about the response to the Ebola outbreak in Central Africa, the U.S. government's response in particular. We will talk about how such outbreaks have typically been handled in the past and explain the impact of the dismantlement of USAID on this crisis. And we'd like to explain how the absence of experienced ambassadors and other professionals, including development professionals serving overseas, has made everything much, much worse. So to discuss all this, we have four former senior U.S. government officials who, I did the math, I think together represent something like 150 years of combined federal experience. And to be clear, serving in both Republican and Democratic administrations over many decades. And we'll start, Deborah Malac served 39 years as a Foreign Service officer with the State Department. Most recently, she was ambassador to Uganda from 2016 to 2020. Earlier, from 2012 to 2015, she was ambassador to Liberia and was heavily involved in the U.S. efforts in response to the Ebola outbreak in 2014. Susan Reichle, to my left, spent 26 years in the Foreign Service with USAID, including as USAID's most senior career official. During the Ebola outbreak in 2014, she was head of the bureau responsible for humanitarian assistance from 2009 to 2010. Daniele Nyirandutiye is a global health and foreign policy expert. She spent 17 years as a U.S. Foreign Service officer, also with USAID. She's managed complex, large-scale health programs, led multiple outbreak responses, including Ebola, plague, polio, and measles across Africa. She served as mission director, also in Uganda, and director for African Affairs at the White House at National Security Council. And then finally, Eric Stromayer. He spent 36 years in the U.S. Foreign Service, including as ambassador to Togo from 2019 to 2022. He was chargé, acting ambassador, effectively at our embassy in Port-au-Prince, Haiti from 22 to 24, and spent a lot of time at the Bureau of African Affairs at the State Department dealing, unfortunately, fairly routinely with global health crises. So I'd like to let these folks have a minute or two of their own to kind of introduce themselves and make a few points. I think it's safe to say we're facing another deadly public health crisis in Central Africa. And speaking as a taxpayer and a citizen, these are exactly the sort of people I would like to see involved in such a crisis right now. So they'll each say a few words, and then we'll open it up to questions from you all. We are all on the record and plan to go about an hour. We'll see as long as your questions last. Okay, why don't we start with you, Susan?
Sure, thank you, Michael. And good morning, everyone. As Michael said, I was the counselor at USAID in Washington during the 2014 outbreak when the CDC warned 1.4 million Africans could be infected by 2015. But we led the international community to halt that outbreak by working alongside African communities. The current outbreak is much larger and has much more momentum than 2014 at the time of detection. In 2014, there were initially 49 cases when we learned of the outbreak, and it took 2.5 months to get over 300. Whereas by the time this administration began responding to this outbreak, there were over 300 lab-confirmed cases in 2 weeks. So we are already massively behind trying to halt the spread of Ebola. Why? Well, there are several reasons. First, if the U.S. had not pulled out of the WHO, we would have learned of the outbreak when it was reported to the WHO on May 5th via the International Health Regulation, which requires member states to immediately report on the Ebola case. Instead, the U.S. did not learn about the outbreak until May 15th, losing a precious 10 days that could have made a huge difference. Second, outbreaks have already been stopped locally, with the U.S. and international community providing rapid support to trusted and trained health workers in the past and community leaders. In 2014, we quickly provided critical protective equipment, lab support, contact tracers, training on safe burial of Ebola victims, and many other interventions. As just one example for you to have from 2014, USAID pre-positioned PPE and was immediately airlifting 130,000 sets of Ebola PPE, which, as you know, is uniquely designed as soon as we were aware of the epidemic. The pre-positioning of PPE and other supplies were not maintained after USAID was dismantled. Those contracts were canceled. And USAID's robust partnerships with local organizations were abruptly halted last year in Ituri province, where the outbreak appears to have begun. We are now seeing the consequences of the decision of this administration to throw USAID into the wood chipper, as Elon Musk declared. Third, the U.S. has relinquished its role as a global health leader. Rather than convening an international coalition for a robust response, as we did in 2014, our response is disjointed, focusing on transporting infected Americans to Europe for treatment or opening a treatment facility in Kenya. By focusing only on how to keep Ebola out of the U.S., rather than stopping transmission at its source, we are making America more vulnerable. Secretary Rubio's announcement that the department has committed $162 million in aid, unfortunately, does not translate into immediate action on the ground by local organizations in Central Africa, who do not have the resources to respond. Our NGO partners in Congo are not able to fully activate because the U.S. had canceled these contracts unnecessarily last year, and they have no assurance that funds are going to arrive on time. Trust was broken last year when partnerships were abruptly ended and bills were left unpaid. We are now running to catch up after chopping off our right leg with the destruction of USAID and hobbling on our left leg with a weakened interagency response led by valiant civil service members. I want to recognize and thank the few career staff members that are now working around the clock. A few recommendations. Name a White House coordinator and institute a robust coordination and chain of command with full transparency. As many of you may have seen, Secretary Rubio, when he was Senator Rubio, called for this in 2014. Second, deploy PPE for all, not just those suspected of Ebola, because anyone using the health system, a pregnant woman going in to deliver a baby, needs to be protected from Ebola. Third, create temporary labs, particularly in the rain countries. We know about Ebola in Uganda and in DRC, but South Sudan has no ability to test for this strain of Ebola. Fourth, invest in communication tools at all levels, from local radio to churches to community gatherings, to regain the trust of communities. And fifth, most importantly, invest in local and international NGOs on the ground. This can only be stopped at the source, in everything from fuel to motorbikes to logistics to safely transport tests and to treat those afflicted. Just want to conclude with a personal story from 2014, where people were working around the clock. I was the counselor in the front office in August when we were dealing with multiple crises. And we were called to the Situation Room at least twice a day, first in the morning, again in the afternoon, working alongside those who were closest to the epidemic. And those people still deserve that type of leadership from the White House and that level of coordination. We are so fortunate to have valiant civil servants and foreign service officers and partners who want to fight this epidemic, and they deserve a better response. Thank you.
Thanks, Susan. PPE, personal protective equipment.
Thank you.
Right. Danielle?
Great. Good morning, everyone. I won't repeat what my colleague has already said about me, but I was, as the last mission director in Uganda, I had to confront the Ebola outbreak in 2025 in the midst of also closing out the mission. So it was quite an interesting time. So for me, I have just a couple of points that I wanted to make. And the first one is that a public health response is necessary. But in this outbreak, it is not sufficient. There's just so many things that are happening. I think you all are watching the news. Having led different responses across the continent, I can say with confidence that at least the lesson that I've learned is that clinical capacity alone does not stop an outbreak. And what stops an outbreak is really a multi-sectoral response that simultaneously engages health, education, agriculture, livestock, local government, and humanitarian actors as equal partners, because we all know that viruses do not respect sector boundaries. In as much as we want and continuously invest in one, they don't respond well to that. USAID, we know this, right, has worked with governments and communities to build institutions, to strengthen communities, and in turn was able to cultivate relationships for over 6 decades. That is 60 plus years of deep technical, operational, and community experience. USAID was that trusted and credible partner in communities. And I can tell you, when I was doing my final tour, saying goodbye to partners in the field, one thing kept coming back. Because of, from the American people, bottles and bags of rice, that's why I am here today, particularly in northern Uganda, where they had gone through really horrific conflict. People recognize what we've been able to do together, from the US to the Ugandan people. So why does this matter? It matters a lot because community trust and credibility are the operational core of any effective outbreak response. Outbreaks like this, they test the relationship between communities and their governments in the most unforgiving way. When people have not seen you deliver consistently, when you have not spent years cultivating relationships on the ground, it becomes really impossible to convince anyone to report cases or to comply with contact tracing or accept treatment. In practice, what does this look like? I think with a multi-sectoral infrastructure that USAID had on the ground, we could engage not only community health workers, but we engage agriculture extension agents. We could engage teachers, religious leaders, traditional leaders, and local authorities in a way that allowed us to call on them when an outbreak like this comes out, so that they can mobilize very quickly. They can counter disinformation, track contacts, and mobilize households simultaneously. And so, and then when members of the communities are ostracized, as they often are, particularly those who actually recover from this disease and they must return to their communities. And the traditional leaders are the ones who really come in handy to help broker that reintegration in the community. And so having those relationships already built really does help. One thing I would say that I've enjoyed during my time working in the field is the relationships we had with the ministries of local government. I think they're often the ministries that are most underfunded and overlooked partners in outbreak responses, yet they hold the community relationships and the local legitimacy that no external health responder can replicate, no matter how much money you bring, because these guys have been there. They're the ones who are responding to local leaders when issues happen. They're the ones who are advocating for communities. And so it's really important to really consider the importance of a multi-sectoral approach. Thirdly, what this outbreak exposes is also the absence of a permanent, empowered intergovernmental coordination infrastructure with real authority and financial flexibility to act. This is at the country level. Now I'm just talking about at the country level. What do we do? How do we make sure that we can actually stop this thing? One Health platforms exist in many countries, and incident command centers have been stood up under international health regulations, working with all the US government, work closely with the World Health Organization and other partners to help put this in place. But the problem is they are too often staffed with technocrats, without political weight, embedded too far down governmental hierarchy, and without enforceable oversight authority across ministries. So what I saw in Madagascar in the midst of an urban plague outbreak, I know every time I say plague, everyone's like, what do you mean? But yes, we had an urban plague outbreak. Our coordination structure led at the highest level of government, particularly by the Prime Minister himself, when he personally directed the response. It meant that resources could be unlocked, interministerial bottlenecks could be broken, and decisions could be made at the speed of the outbreak. That is the model that we need to embrace, that countries need to embrace, and all of us international partners need to rally behind and help countries elevate. They need the permanent coordination entities that report directly to a higher level beyond technical ministries. They need to have a mandate to direct and redeploy resources across sectors without negotiating that authority in the middle of an emergency crisis, which I think all of us who are in the field, we can attest to. When you get to a meeting and Ministry of Health is fighting with Ministry of I don't know who, and no one wants to move. We also need to have these entities really serve as a single entity that is accountable to receiving or incoming international assistance. Because again, we want to make sure that we are continuously learning from the past, but we're also empowering countries to do better, alongside what my colleague has already mentioned. Because at the end of the day, what we want is to have aid be strategically deployed rather than fragmented across dozens of parallel partner pipelines. But the architecture itself is not enough. What we also need, and what USAID worked to do, was to ensure that this architecture were staffed with people with seniority, but that we could lobby and advocate for adequate resources for these entities, because oftentimes what you see, they come to meetings, they are aware of things, but they can't say anything. They don't even have money. Sometimes, they're coming on a boda, right? On a motorcycle, but they don't even have money for fuel. So they need to be resourced adequately, and they need to have the right people in place. So I'll end by saying that we need this structural shift needs to happen, and the community needs to come from both the countries that are affected, even those that are not affected yet, because I think as we've seen, the transmission from animal to human is going to be a constant as the population continues to grow. And so we are going to constantly contend with these infectious diseases. And so we do need to have robust infrastructure that's in place that we can all get behind and support in this kind of situation. Thank you.
Thanks, Danielle. Deborah?
Yes, I'm going to be brief because I don't want to repeat all the wonderful stuff that my colleagues have said here, but I think what you can take away from this is we know how to stop an outbreak, particularly an Ebola outbreak. We know the pieces that need to be in place in order to do that. And it's early detection, it's surveillance, it's lab capacity, it's community health workers, it's contact tracing. But the underpinning of all of this, as you've heard from the others, is community trust and community involvement, because without that, it all falls apart, because you can bring in as many people or as much supplies or as many treatment centers, but if people don't understand what's happening around them, they don't trust what they are being told, it won't work, and you will continue to see the spread because people will hide, they will not report, they will not show up to seek treatment, and then what you have is an uncontrolled epidemic. And speaking as someone who was on the ground in 2014, Susan speaks a lot about what happened sort of August, September, when we became much more heavily engaged in the response. I can tell you that the first several months of this, we were chasing the epidemic. I mean, I have flashbacks when I read about what's happening in Central Africa at the moment. I go, this sounds very familiar. The numbers are obviously a bit larger, but we were confronting a disease that had not been seen in this region before. There was no capacity apparent to actually fight the disease. So it becomes, we had to create those structures and those response mechanisms. And so a lot of what we're talking about now, which has now disappeared, is infrastructure or architecture that was created as a result of lessons learned during 2014. Up until August of 2014, this was not considered a humanitarian response. I personally had to declare a disaster in order to get USAID and the US government to say, we need to do this. And as a result, we built up over the course of the next couple of years these mechanisms to allow us to more efficiently and effectively respond when new disease outbreaks happened. There were also commensurate investments in the global health security agenda, which also created structures, but more importantly, created indigenous capacity in countries. Uganda is a case in point, where they were able to build up their own capacity to better do disease surveillance, outbreak response. And as a result, in 2018, when I was ambassador to Uganda, and we had another Ebola outbreak in the Eastern DRC, which bled into Uganda, we were able to very quickly move resources, work with local partners to continue to contain it and keep it from becoming very, very large and getting out of hand. So what we see now is with the closure of USAID, with the dismantling of those local networks and relationships, it becomes very, very difficult to do that quickly because that trust is gone. You have to spend the time again to rebuild the trust. And believe me, I know from 2014, that is a very difficult process. And just like and I will just say, if you're asking why actual diplomats as opposed to development specialists are part of this conversation, the reality is, as you heard from Danielle, it must be an intergovernmental effect of response, a whole of government response. And you need those relationships on the government side to work with the people who are trying to respond. And so we've also demolished those relationships. And so we need to figure out how we can better be prepared in the future. I'll stop there.
Thanks, Deborah. Eric?
Hi. I can only echo, I think, the detailed analysis that my partners up here have presented. I'll be very brief. I had longer sort of remarks that I thought I'd present, but I don't think they're particularly germane to the focus that you have. I was here in Washington. I was what we call our regional executive director for the African Bureau. I provided logistical support to the embassies that were affected most by that outbreak, which were Liberia, Conakry, and Sierra Leone. Based on my experience with Ebola then, and later with COVID when I was ambassador in Togo, and cholera when I was in Haiti, I cannot emphasize enough, as has been raised here, the role our ambassadors and coordinators of a response and the country team did and can play in responding to any kind of unanticipated outbreak of emergency or viral diseases. Time is critical in these cases, and having the kinds of structures that had to be built back in 14-15 and being able to rely on them, as we were able to in outbreaks that occurred subsequently, as some of my panelists colleagues have mentioned, is absolutely crucial. The U.S. role as a coordinator through USAID and CDC with international bilateral and multilateral partners in these experiences can't be overstressed. Our role as a major supplier of needed relief supplies cannot be understated. The need for establishing SOPs that are on the shelf, ready to be mobilized to rush supplies and personnel to a future outbreak site, whatever it is, whether it's Ebola or something else, is a lesson learned, a lesson that was applied in subsequent outbreaks. In that context, then, I would simply urge the administration to redouble its efforts to rebuild capacity to respond to crises like this. No other country has the global reach we do. We need some sort of a USG coordinator for response. Ambassadors need to be assigned in those places where they aren't, because these kinds of things can break out anywhere. They don't have to be just in remote parts of Africa. Experts rehired, emergency response capacity with international partners, and stocks has to be rebuilt. Supply chains and partners need to be re-identified if they've been lost or if they've gone out of business. And people who are working this now, I salute them. I mean, it is not easy work at all, but it needs full-blooded support. Again, and I don't think any of us can stress this enough, it's not if, but when further outbreaks of Ebola or other contagious diseases will occur. We need to be ready. It is a matter of our national security to be able to respond in the field and stop these things as quickly as possible when they break out. So I'll stop there.
Thanks, Eric. So thank you, all of you. Bottom line, look, global health crises, it's a humanitarian issue, and America responds because it's the right thing to do. It's a national security issue. We respond because it protects our friends, our partners, our allies, and our own citizens. And what's very clear to me is America has the expertise and the tools to respond competently and quickly. The key is deploying those tools and deploying those personnel quickly and competently, and frankly, without reference to politics. So with that, happy to take your questions. Could I ask real quick, we have how many people online?
There are 7 folks online.
7, okay, very good. Why don't we start here? Anybody, please?
I have a question
Amen.
for Madam Ambassador. Because you were in Liberia in 2014, and the U.S. brought home Kent Brantley and Nancy Reichle, I was wondering what your thoughts are about the U.S. policy, the White House's policy now, to absolutely not bring home American citizens who are exposed to Ebola.
Well, I think you have first, there's a constitutional issue in my point of view. If you're an American citizen, you do have a right to return to your country. So that in and of itself is a bit of a problem for me, I think, from the outset. But this was one of the things that grew out of 2014. The State Department was working with Phoenix Air to help develop the capacity to be able to evacuate people safely who were already infected, right? And that Kent Brantley and Nancy Reichle were the first 2 Americans in Liberia to be infected, and then were brought back to the U.S. And that capacity has continued to grow and improve over the years. So if it's someone who's actively infected, they should be allowed to come back here, take advantage of the care that's available at these various centers that we have spent a lot of money to establish, and can treat them safely. I think it's a very short-sighted policy, and this idea of somehow parking American citizens in a facility, I guess the discussion is currently in Kenya, whether that will happen or not, I don't know, to hold them for 21 days just to observe them. I traveled back and forth from Liberia, from West Africa to the United States several times during the course of 2014 and 2015. I was subject to, public health screening at the border. I would, monitored my temperature every day while I was home in the States, reported to the public health, my local public health office. There are ways to do this where you can safely do it and not be a threat to broader spread. And I think Americans should be allowed to come home. And if they're sick, they should have access to the treatment that we can provide here. And if they're simply, possibly exposed, there are ways to manage that as well.
Andrew?
Yeah, thank you very much for this. I was curious, just given your experience in government and likely many of the people that you still speak to who are there or close to the government, basically, to what degree the lessons and the ideas that you were sort of suggesting are being pushed through towards those in power at the moment, those who make decisions? Do you feel like those discussions are happening?
Well, I think we are. I'll start and then
Yeah.
pass it on to my colleagues. As I emphasized in my remarks, I think we are very fortunate that we still do have people who are serving with experience, who are working literally around the clock. I mean, maybe getting 2 or 3 hours of sleep a night, as this is a marathon. And they are taking that experience, they are trying to feed it up the chain. I was pleased to hear yesterday that Secretary Rubio, there was discussion about having someone appointed as a White House coordinator, because leadership from the top is absolutely essential when you have a crisis, and particularly a humanitarian crisis. I understand, are trying to again catch up and they just established the task force, as you know. They are starting to have daily calls that people have been deployed to the region. Unfortunately, they're in the capital of Kinshasa. They are very far from the epicenter. So they're getting there, but we are very much behind. And I think the lessons, yes, we want to help this government, our country, be successful. That is what this is about, because as Michael said, we have the expertise, we have the experience, and we want to do everything that we possibly can. We continue to serve even as we retire.
Yeah, I think,
Go ahead. No,
from
go
my
ahead,
perspective, what I would say is that when I look back at Uganda, I had a staff of 215 people. So you had professionals who were working in different sectors. And so when we had to close down USAID, just a handful on one hand were transitioned to the State Department. So we have lost experts in agriculture, as I said, education, and all these other sectors that where we were working, we had relationships in government at the highest level all the way down. And so when you don't have that, we don't have that actually. It's not, but we don't have that at the moment. And it's not something you can bring back all of a sudden. So when we had outbreaks, these people will be the ones who would plug into different conversations to say, how is the agriculture sector thinking about this outbreak? How is the education sector thinking about this outbreak? How can we ensure that kids can go to school and be safe and not, be infected or go home and infect others? All of these questions are critically important if we want to really be able to stop this outbreak. And so the US government does not have that. Meaning like because the stuff are gone, they're not there anymore. And so we're gonna have to figure out other ways to do it, whether we do it through other partners, but I can also tell you that other partners do not have the deep connection and the extensive networks that we had because we had been there for a long time. We knew the field, and a lot of the staff, they had worked in some of these regions, many of them. So we don't have that. So for me, that's what worries me, and that's why I think it's really important that we move away from just a public health response to a multi-sectoral response and consider how we tap some of these experts that are out there that need to be brought into this U.S. government response, actually international response, I should say, and figure out how can we tap their expertise to get it done.
Thank you. There's some hands up. Well, let's go to one of the online ones, and then we'll get to you, if that's okay.
So we have 2 questions on Zoom. The first is, earlier this week, lawmakers raised concerns about how U.S. aid cuts were affecting early disease warning and detection programs on the African continent, and Secretary Rubio responded that, quote, it had nothing to do with the Ebola outbreak. What is your reaction to that, and what does it say about the way the State Department is approaching the response?
Well, let me just say quickly, you don't respond to an outbreak when the outbreak happens. It's preparedness. And what this administration did was they cut the contracts, they stopped the preparedness, the pre-positioning of the protective equipment, the people on the ground, the contracts that the partners that Danielle talked about, those relationships were fractured. So when he said that we're responding faster than 2014,
That was she was making a nose.
no comment.
Face, yeah.
Yes. That is absolutely absurd.
Did you want to add something?
Well, I think Susan has pretty well addressed it, but there are, I do know that some of the programming related to zoonotic alerts and early warning systems have been weakened. They may not have been completely dismantled, but the programs that had, for disease surveillance for new and emerging diseases has been weakened considerably. And again, early detection is really critical to prevent outbreaks from getting out of hand, whether it's Ebola, chikungunya, Zika, take your pick of the petri dish of things that are out there.
I mean, if I could add, I had the occasion to travel between Conakry to Freetown overland during the Ebola crisis, and the depth of the response was reflected in checkpoints every 5 to 10 kilometers where people would come out. They would check your temperature. There was facilities there in case they did determine somebody had a higher temperature, and it was consistent across the entire way from Concrete to Freetown. And that reflected the depth of the response, not to mention the breadth of the material that needed to be there, the PPE, the tents, the equipment to go ahead and make sure there was plenty of clean fluids, clean water, and so on. And the other things that I don't have the expertise to determine, but that's the kind of it's like a fire department that's been disbanded. Yeah, there's a fire, we're trying to respond to the fire, but the fire trucks they don't have gas in them perhaps, or that's this kind of analogy I would draw.
I do think we need to say something about WHO in all of this, right? So the US withdrawal from WHO is a very short-sighted and ridiculous move. WHO did not cover itself in glory in the early days of the Ebola response in 2014. I can tell you firsthand that there were a lot of issues. But what happened, again, one of those lessons out of 2014, and a lot of work was done with USAID and CDC to work with WHO to improve and create better emergency response capacity. And they have deployed that in the past, and they are deploying it now, and thank goodness they are, because at least there is something additional to bolster the Ugandan government and the DRC government and local officials to be able to respond. But the fact that we cannot communicate with them, that we cannot share information with them, we don't have a good sense. I think just this morning I heard that no one has a good sense on the contact tracing side, knowing just exactly what is happening on the ground. Again, it comes back to those local communities, those local relationships, and organizations that have been working there over time. Simply throwing money to one or two of those organizations who may already be on the ground working is not going to be sufficient to address the problem.
Thanks. Hey, can I ask who asked that question?
That was from Devex, and they have a second question if you'd like to do.
Can we hold on that?
Sure.
You're next. We'll go to that one and then you, if that's okay.
Thanks so much for doing this. One of the arguments we hear from the administration repeatedly is that no specific programs tied to this were cut. That CDC experts are still on the ground, that they have these local health partnerships. And I know you're speaking about the importance of maintaining, of building these relationships and the trust that comes there. But in addition to the PPE being pre-positioned, are there specific programs that you can point to that were cut, in response to that?
I'm sure we could get you a list because there were. DRC was one of our largest programs at USAID. It was also one of the largest recipients of humanitarian assistance. And so programs were cut. And most importantly, as Danielle emphasized, it wasn't just the programs, it was the local relationships. It was the local partnerships. It was our relationships with ministries. There's a lack of trust and confidence. So for them to say nothing was cut just doesn't seem to ring true.
Yeah, I mean, and one thing to underline that again came up in my experience was that there's sort of dual usage, if you will. I mean, a program that was designed, say, for the President's Malaria Initiative or for PEPFAR can provide facilities that then can be used perhaps to respond to this kind of thing. So if you cut those programs, that undermines local capacity to reflex, if you will, and respond to this kind of an outbreak.
Right.
We can endeavor to get you some more specifics if you like. We can share that with anybody that's
But it's not
that.
true.
You have another question on?
Yes, so this is also from Devex. What is your
What
understanding?
is DevX? Sorry.
It's a development magazine.
It's development communities.
It's developing
Oh, okay.
community,
My
information.
sorry, go ahead.
What is your understanding of the way the bilateral health agreement is playing out in the Congo as it relates to the Ebola response? Pandemic preparedness was a core piece of that. Any light into how this has been implemented?
I don't know how many of us know many details about these bilateral agreements. From what I understand, there's been a stunning lack of transparency around the details and the content of many of these bilateral agreements. We get little bits and pieces. And yes, from what I do know about, I don't know specifically about the one with DRC, but I have a little bit of information about the one with Uganda. My understanding is that they have talked about some of these elements that were part of the global health security agenda, so surveillance, response. But I think that in and of itself is telling. If these are instruments that are in place and are supposed to be governing these kinds of responses, then there should not be so much secrecy surrounding those compacts. Also, they are all quite new. And yes, they have host government requirements and obligations as a part of that, without sort of really knowing what capacity that host government has to meet those obligations in the short and medium and long term. So to go from systems and infrastructure that was in place and programs that were working and relationships that were existing, cut those off completely and then somehow say we've kept them going by negotiating a new agreement, that doesn't automatically connect the pieces that were severed. But I think that's something that we don't have, being outside the system at this point, don't necessarily have any transparency on.
Thank you.
Yes, I wanted to follow up on the biocontainment capacity in the United States, and I think a talking point that we're hearing from the administration is this argument that there's some medical reason why it would be better for infected patients to be treated at geographically closer facilities. So I was wondering if you had any comment on whether that's like a reasonable argument to make.
Well, certainly, okay, I will preface this by saying I am not a medical person, obviously, but I feel like from my experience and having lots of conversations, certainly in 2014 and dealing with this, I can at least make a couple of comments about it. Certainly speed is of the essence. If someone is actually showing symptoms, obviously the sooner you can get them into care, the better their prospects of recovery are. That is a given, and that's often true in most instances with disease. And so, putting someone into a capsule and basically sending them back to the U.S. from somewhere in Central Africa or East Africa or even West Africa is a long and lengthy process. So you're reducing that window by some amount of time. But the issue then is what kind of care you are getting and how quickly you can get them into higher level care, which goes beyond it's more enhanced supportive care. I think that's a bit of a canard, because ultimately what's very clear, and I believe it's also in all of these global health, these bilateral compacts that they're signing with countries, is that the idea is to keep the disease out of the country. And fair enough, we don't want communities being infected unnecessarily, but I think they're using that as a justification for keeping people out.
Yeah. In 2014, yes, to add on to what Deb said, we remember this very well. We had to really do everything, right? We needed to have facilities close to where obviously health workers and others were exposed, because we weren't going to get the international community to be able to respond if there wasn't a facility there very close, right? Not in another country, but close to where they were exposed, close to where they were having symptoms. Then we had to work with the U.S. military, and we haven't mentioned the key role that the U.S. military played in 2014. Ultimately, they were essential in helping us set up and deploy troops. I think it was about 3,000 or so that we had.
Only two.
Sorry?
Only 2,000.
Okay, 2,000. Thank you, Deb, for correcting me. But it was also the plane and having, in order to get people who were infected and very sick back to the U.S. to the 13 facilities that were cleared to do that. We have a video on this if anybody is interested. Now, years later, interviewing the doctors down in Dallas and people who were exposed and what that experience was like. So this is a very complicated time. I also remember it was right before Thanksgiving. It was probably in October when we were massively trying to prepare for this, because again, people were coming home from the region to see their families. A lot of Americans live in Africa who then travel. And so how do we actually make it so that, again, as Deb said, we don't want to expose anyone in the United States or anywhere, but you have to go to the source. You have to work at the source, and you have to create, again, systems. The logistics are extraordinarily complicated, and that's what they need to do.
Sorry, do we have anyone else online right now?
No other questions at the moment.
Okay. Let me go to AP and then to you.
Off of this same point, when it comes to bringing U.S. American citizens home and these 13 facilities, I know one of them's at Dulles International Airport. We have archived video of like Anthony Fauci showing it off then, and I'm curious if they're even in use as of right now. These facilities that have a lot of capacity to keep the outbreak contained and bring these people home. I mean, are you guys aware of any use of them right now? And do you think it's underutilized? Do you think it's something that optically they're afraid to use because they'll be bringing, people who are infected to the U.S. and that could cause some extra fear?
Well, they do have the hantavirus folks in Nebraska. I think they're still there because it's a longer incubation period, 42 days or whatever, as opposed to 21 for Ebola. But I mean, these facilities, the U.S. government made the investment to build this capacity for precisely these kinds of situations where you could bring people in, they could get the kind of treatment and care they needed to get, and yet protect the community, protect the country, if you will, from broader spread. So I don't know if you can say they're underutilized. I mean, it's not like we have outbreaks of things like Ebola every day, but there certainly is space and capacity available to be able to treat these folks.
Do you think there's a broader hesitation from the Trump administration to bring any U.S. citizens home because of the optics of, we could be bringing Ebola to the U.S.?
Well, I think that's exactly the point, that they're afraid to bring anything. I mean, Secretary Rubio has been very clear, there will be no Ebola in the United States. I mean, they've said that we will not let it into our country, but, that's a lot different to say if it were just spontaneously an outbreak or there were, something different.
I mean, one thing that I guess I would add also, sort of anecdotally, I mean, obviously a critical role in the field, but also here in the country at the highest level, is explaining what Ebola is and isn't, and demystifying it. And so, I mean, one of the things that I took away from my experience supporting our missions in the field in 14, 15, was, to me, the remarkable fact that once people did know how to control it, there was absolutely no incidence among American local staff or local staff's families of Ebola once they understood how to contain it and not get it. And so, I mean, it's not like COVID in that sense. I mean, thank God. And so, to the degree that it's not, it is something that can be managed, hence the fact that we did manage those cases coming back. I too remember coming back and being told to call in every morning with my temperature and so on and so on. And I know they would have reacted if I would have. In fact, I run a degree short or something. And so they were like, are you taking Tylenol or something? Why is your temperature low? And so it can be done. And again, it's a constitutional right. Americans should be able to come back to their country.
And just to be clear, it's always precarious to try to get inside the heads of current policymakers right now and discern their motivations. I mean, you see the same public commentary that we do, so I would just draw the distinction between what's driving their decisions and what we can offer in terms of what we think ought to be happening, particularly overseas. We have one here, and then we can go with you.
Thanks so much for doing this. This is more of a general question about the plans for the facility in Kenya. I mean, obviously that's faced legal challenges, but the U.S. is already sinking money into it. And something that's been a little unclear is what kind of consular demand the administration might be expecting. And I know there are a lot of undefined variables right now, but the initial plan to have 50 beds for Americans at that facility, does that number strike you as potentially adequate? Of course, it could be scaled up if this actually does take hold, but it seems 50, is that a small number or?
Well, working off of what we had in Monrovia, the Monrovia Medical Unit, which was basically an Air Force installed field hospital that was specially designed to mimic the treatment facility, an Ebola treatment facility. So the one way in and one way out kind of process, the things that needed to happen, was smaller than that. But we didn't have a place for suspected cases or those who'd been exposed. It was really for people who had already been exposed, were showing symptoms and were sick. So it was a little bit different. So the number didn't need to be quite so large, but could have been expanded if that were necessary. Fortunately, we did not have to expand it. So it's hard to know. We're not part of the conversations about what this facility would look like. But my assumption is that when they announce this, that it would be very much modeled on what was in Monrovia during the 2014 outbreak. So a treatment portion, as so that at least initially, even if whether they decide to let them stay there or they would send them to Europe for treatment, there would be some ability to treat, but then an area that would, these are, large canvas tents, so a place where people could stay and be under observation or monitoring to see if they became ill. 50 bed. I'm assuming they're picking a number out of area to start somewhere, but it's probably a realistic size, at least for the start.
Is there any logic, just to follow up, any logic in having that in Kenya and not Monrovia directly impacting?
We can't, just to echo what Michael said, we can't get inside the head of why they're doing this. My guess is the government has a good relationship with the government of Kenya, and they presumably want to do this in a place that does not have Ebola actively spreading. So they picked it off the map, I guess, and they do have one of these health compacts. So I think it's a lot of, just something that made sense to them. It's fairly close to the region, although the transport from Eastern Congo to Kenya in order to do this is a whole nother issue, especially if you think people have been exposed, and the reason you're putting them into this facility is to keep them from potentially exposing others. How do you transport them safely, and where would they be coming from? Maybe they've already been in South Sudan, or they've already been someplace in Uganda. So
we've got two
The
questions.
real one online, no.
We've got two questions from Stat Health News. The first one is, can you comment on the way the U.S. appears to be using bilateral agreements to push countries to agree to their demands? I'm thinking about Kenya. It seems the whole funding to their health system, not just the $13.5 million recently pledged, could be in jeopardy if the facility for Americans doesn't go through.
Any bids on that?
I don't think we have any visibility on that. It goes back to the comments that we made earlier on these bilateral agreements. There's not a lot of information, not a lot of publicly available information about what's contained in those agreements. And so I think we would not really be in a position to comment on that.
Was that both questions?
The second question is, you discussed the importance of local support and trust. Do you think it's actually possible at this point for the U.S. to be seen as a reliable ally?
I think it's very, very difficult. I'll let Danielle respond to that because she's been on the ground. She knows these relationships. And ultimately what we say in development, it's all about people, right? What we do, it's working directly with people, so.
I would say that the relationships are still there, not as in the state they were in prior to what happened in 2020 last year. And the reason I say that is, again, when I was doing my final farewells around the country, one thing that I kept hearing time and time again, it was just like, the deep appreciation that people had for what had been done on the ground, but also the hope that the U.S. will be back, and that somehow we will continue to interact. So I think that the goodwill does not disappear overnight, but it's under strain. It's not going to be there indefinitely. Certainly not.
I think that's true, but I do think that all of the actions, not just what's happened with USAID, but a lot of what's happened. We have over 100 embassies that don't have ambassadors, for example, currently. A lot of the different sort of on again, off again with trade policy, with threats to do certain things. and I hear this from, I still have contacts in some of the countries where I served and from around the world. I think it's very hard for people to see us as a reliable partner based on the decisions that have been made. And I think this is why we, as sort of development professionals, diplomats, we worry about how we get back to a point where we can do the important work that we need to do based on these international relationships, based on the trust that we've developed over decades, in order to keep our country safe. If this is ultimately about national security and national interests for the United States, we need those relationships. We need those friends. We need even with our adversaries, we need to be able to have a relationship and speak to them and understand where things are coming from.
And I think I will add as well that a lot of these countries, they have come to expect the U.S. to take an approach that's very fragmented, an approach that is oftentimes incoherent. No, really, that's what they've come to expect. Mm-hmm. And so when you go to meetings, they will say, "Oh, you are back. Yesterday you said you didn't want to talk to me, but now you're back." So they have learned to essentially almost adapt to our incoherence and our fragmentation. I'm not saying that it's a good thing, but we are where we are, and that's going to require a lot of work to come back from it.
I'd only add, it's not just a bilateral relationship.
Right.
Other countries are watching how we interact with our supposed partners.
Yes.
And can exploit it. You had one question, and then we're in an hour, so I think we'll break that.
Actually, I have two different questions. One, I know you addressed this to some degree, but can you talk a little bit more about the way the U.S. and the World Health Organization would have coordinated on the ground in the past and what is lost now with the U.S. no longer being a member? And then separately, given the issues you just described about the international response and the current state of like the U.S. diplomatic presence around the world, do you see any issues coming up around global coordination for Ebola prevention around the World Cup?
Yeah, I'll let you all talk about the World Health Organization on the ground, but I'll just briefly say, it is absolutely essential that we be a member of the World Health Organization. It is the collaborative body for all of its challenges, and I think we all recognize the challenges of the WHO. It's absolutely pivotal. And pulling out, this is an example. We lost 10 days, and 10 days is a lot in a pandemic. And then on the international coordination around the World Cup, this is enormous. This is an enormous challenge. Again, to emphasize what our colleagues said, that we know how this strain of Ebola is passed. It is not passed like COVID, so the disinformation we really have to keep away. And it really takes constructive engagement and a lot of just planning. And I think we're deeply worried. And we hope, because as Michael and my colleagues have said, we don't know how they're planning. And we really want to do everything to make sure that we're successful. And so please, I think just look at what we've done in the past with big events when there have been pandemics and epidemics and how we've been able to move forward. So.
I don't know that there's much more to add on the ground level with WHO. Obviously, they were very much part of all coordination meetings. And, what we do need to remember is that, the host governments have to be in the lead on all of this. And again, because they're the ones who live there, it's their citizens who are being affected. But WHO definitely's capacity has improved over the last several years, but they were a very integral part and partner to us, and we could burden share, if you will. So WHO would handle certain things, we would handle others. But the big key is that not being able to share data with them, not being able to communicate with them and get information because we're no longer part of the organization. It again is like tying a hand behind your back to try to get even accurate information, because now you're relying on getting it from other sources, which may or may not be as comprehensive as what the WHO has.
One of you could correct me if I'm wrong, but as a member, we would have had personnel in WHO who would be seconded to them, who would then be able to transfer information to their partners. I mean, these would be people coming normally from U.S. government or NGO,
yes, that's true.
who would be contacting their counterparts outside of the WHO and saying, hey, guess what? We've just heard this disturbing report out of whatever. Well, those people aren't there anymore.
Yeah, and I think maybe the another point I will add is the storage capacity that you would expect from WHO in situations like this. They deploy large teams on the ground to supplement the local team. And so I think with this outbreak, that is from what I've heard, is that it's not the same. It's not the same surge capacity that we're seeing on the ground. So because their funding is also being severely constrained. So I think it's slightly different.
Good, thank you. Anyway, thanks to you this was terrific, and thanks to all of you for covering this story. It's an important story. Let me just say, if you want to follow up individually with any of these folks, just say hello, and obviously it's up to you how you want to handle that. American Academy of Diplomacy, it's really, I'm new to it, but it's striking how much experience there is, and I know journalists often contact AAD for expertise on specific areas, and obviously feel free to do that. Also, this is the second in what we hope is a long series of kind of focusing our expertise on topical issues and inviting journalists to cover that directly. So did one on the sort of evacuation of American citizens and personnel during the beginning of the Iran war. This is the second one, and as these things emerge, stay tuned. As you cover this story based on comments today, to the extent, and we track this, we try to track it, but if there's stories you write, share them with us so we can kind of get a sense of what's getting written on this. It'd be appreciated.